Thank you. So, in 1927, a Mayo physician published this, saying that we have recently studied both clinically and at necropsy a case of severe spontaneous hypoglycemia. This is attributed to a tumor of islands of Langerhans with metastasis in the liver and lymph nodes. The condition has not been described heretofore, and in this sense, it represents a new disease. So let's talk about benign version of the disease at least. I'm talking about hypoglycemia. This is a case-based discussion. So if somebody wants to interrupt me anytime, please raise your hand and I will stop there. The first question that comes if we suspect hypoglycemia in a person is if the person has diabetes or not. And of course, if there is diabetes, we treat hypoglycemia if there is suspicion of hypoglycemia. Well, then we find a cause and try to prevent it. And I'm not going to talk about that. Today, we are talking about non-diabetic hypoglycemia. So if it's non-diabetic hypoglycemia, we want to find out as much as possible, first of all, not to treat the patient, not to treat hypoglycemia, if at all possible, and draw blood first. And what are we drawing blood for? We're drawing blood for plasma glucose and other things. Plasma glucose to establish what is called Whipple's triad, and this is sort of modified Whipple's triad, if you may, which includes number one, symptoms of hypoglycemia, and modification is that we would prefer neurological symptoms of hypoglycemia, that there is a documentation of low glucose, and the modification is plasma glucose at the time of symptoms, not capillary meter glucose, not sense or interstitial glucose, but plasma glucose. And relief of symptoms when the plasma glucose concentration is raised back to normal, and hopefully documentation of all that. That is Whipple's triad, and that's what you want to use, documentation. So that's why we draw plasma glucose. But if plasma glucose is 60 milligram per deciliter or less, then we want to see if this low glucose is because of some insulin-like action that is causing low glucose. And how do we do that? We measure beta-hydroxybutyrate and glucose response to injection of glucagon. Let me explain to you. Insulin, by its action on muscle, liver, and fat, causes glucose concentration in blood to go down. But insulin also, through its action on fat and liver, suppresses ketone production. In addition, when insulin works on liver, it causes storage of glucose in the liver in form of glycogen. And if we give injection of glucagon, glucose is released from the liver if glucose was stored in the liver, promptly released after injection of glucagon. Therefore, the release of glucose after injection of glucagon and ketone levels in blood, these two tests say that there is insulin-like action happening. That is how we can find out there is insulin-like action happening. Now, if the glucose is low, the beta-hydroxybutyrate or ketone level, blood ketone level is suppressed, then there is insulin-like action. If there is a robust response of glucose after injection of glucagon, that means there was glycogen, that means there was robust insulin response, insulin action. So if there is insulin type of action, the next question is obvious, is there insulin in blood? If there is no insulin in blood, then there is something like insulin which is working. Otherwise, if it is insulin in blood, it is insulin that is causing it. If glucose is low, there should be no insulin. There is no need to bring down glucose any further. So insulin levels should go down if glucose goes down unless insulin is causing it. So normal glucose is not normal if the normal insulin is not normal if glucose concentration is low. If insulin is there, then we want to find out, is insulin being secreted or not? And how do we do that? We measure C-peptide and proinsulin. Let me explain that too. For each pro-insulin molecule in the secretory granule endoplasmic reticulum converted to proinsulin is broken down into insulin and C-peptide. So whenever a molecule of insulin is released into circulation, a molecule of C-peptide is released in circulation as well. Insulin has a very short half-life, 7 minutes, 6 minutes, other than C-peptide has much longer half-life, between 30 to 60 minutes. So C-peptide is a better marker of insulin secretion than insulin itself. And of course, insulin can be injected. C-peptide is not available for injection. In addition, proinsulin is also released directly into circulation. Therefore, for each molecule of insulin that is being produced and secreted, we can see proinsulin and C-peptide as a marker of insulin not being injected but endogenously produced. So these are good markers of insulin secretion. So now if insulin is being secreted, which is causing insulin action, which is causing low glucose as documented by Whipple's triad, then the next obvious question is, what is it that is causing it? So we measure sulfonylureas in blood and find out if there are agents in blood that will trigger insulin release or not. If their blood does not have sulfonylureas, then it is spontaneous release of insulin that is causing insulin action, that is causing hypoglycemia. So let's start with the cases then. Case number 1, a patient with spells suspected of having hypoglycemia, sweating, palpitations, headache, lightheadedness. Home meter glucose had shown several numbers in 40 milligram per deciliter. Patient was hospitalized. Dr. Meera Shah was actually the fellow at that time. So this patient was hospitalized, and this is the 72-hour fast ongoing. And this about 48 hours into the fast, the glucose concentration, then the patient had a typical symptom of glucose. And here on the y-axis is capillary glucose. As you can see, capillary glucose plummeted at the time when patient had her typical symptoms of hypoglycemia. Well, then what should we do in this case? Should we draw plasma glucose? Should we do C-peptide, proinsulin, etc.? Should we feed glucagon, 4D-CT, etc.? These are questions that come to mind, but let me tell you what happened. What happened was, after a few minutes, these symptoms disappeared and the glucose, capillary glucose concentration went up. But we don't only measure capillary glucose, because in Whipple's triad we said we want plasma glucose. We also measure plasma glucose in these patients, and that is plasma glucose. And as you can see, right when capillary glucose was in 40s, plasma glucose was completely normal. So this is not hypoglycemia. Capillary glucose is low. That is not hypoglycemia. If plasma glucose is not low. So all we needed for this person is plasma glucose. Next is a patient who was hospitalized to one of our cancer hospitals on service. Once we were called in to say, please come and see a patient, we are having hypoglycemia. Glucose concentration is 21 milligram per deciliter. We looked at the chart, and actually the previous day's glucose was 23 milligrams. This is lab glucose. This is not capillary or meter glucose. They have usual morning blood draws, and that lab glucose was 21 and 23 milligram per deciliter. So the question then is, what could be causing this patient of acute leukemia having plasma glucose of 21 and 23 milligram per deciliter? Well, actually none of the above. Patient had no symptoms of hypoglycemia. Therefore, it is not hypoglycemia. It is 21 glucose from the lab. That is not normal, but it is not hypoglycemia. It is just low plasma glucose, and this plasma glucose was low because the patient's white cell count was so high that it was chewing up the glucose between the draw and the blood test, which happens within minutes at Mayo Clinic. There are very smooth systems which work, but within those minutes, the glucose is being chewed up by the white cells. Actually, the capillary glucose at that time was 85 milligram per deciliter when measured the next day. So this is not hypoglycemia also. So the point here is that first thing to do is to collect blood and, based on Whipple's triad, find out whether there is hypoglycemia or not hypoglycemia. This is a patient who was hospitalized with acute pancreatitis in our gastroenterology service, and was receiving intravenous pain control and intravenous antibiotics. And this is what we were called in when the glucose was 43. Previous day's glucose was also 41. We went to the patient. This all blood was tested before we were called in. And so I'm putting them all here for you to see. In retrospect, she said, yeah, she had some symptoms, and after she ate, she felt better. So the question there comes up as to what does this indicate? Does she have insulinoma, sulfonylurea, etc., etc.? And the bottom line here is that none of the above. If hypoglycemia has happened for the first time in hospital, it is not because of anything related to insulin production, secretion, tumor, etc., etc. It's all because of drugs, drugs, and drugs. And this patient was receiving IV moxifloxacin, which is well known to cause beta cell release of insulin and even diabetes. But so usually there are drugs in hospital. Patient is sick. If hypoglycemia is present, the next question is patient is sick or not. And if patient is sick, medicine history, medicine history, that will tell us what is happening. None of the tests are going to tell us anything else. So if this is a patient who was not sick now, a 24-year-old woman whose sister has type 1 diabetes, had spells with documented low plasma glucose in the past. She underwent a supervised fast at 36 hours. She had a typical spell, and during the spell, this is the reports, and this is done by us, so let me go through it. Plasma glucose is low, patient is symptomatic. We have Whipple's triad. Earlier she has treated and corrected, and we have Whipple's triad. We have documentation of hypoglycemia, diagnosis of hypoglycemia. Beta hydroxybutyrate is completely suppressed, and there is a more than 25 milligram per deciliter response of glucose after injection of glucagon. That means there is insulin-like action that is causing hypoglycemia, that is causing her symptoms. But there is no insulin. And there is no insulin secretion. Both C-peptide and proinsulin are suppressed. Insulin is suppressed. So there is insulin-like action, but not from insulin. Now, where do I go now, right? So the question is, where do we go? Should we look for malignancy, measure IGF-2, screen for hypoglycemic agents? And actually the right answer is talk to Dr. Ravinder Singh. Dr. Ravinder Singh he's moved to Arizona, but he was our endocrine testing center, endocrine laboratories in charge of Mayo Medical Laboratories. We talked to him. And what they did was, well, let me show you some of the data in graphical form, first of all. So this is what happened when typical spell of capillary glucose. This is what happened plasma glucose. So we have low documentation of low glucoses both the times. When the glucose concentration went low, actually the beta hydroxybutyrate concentration went down at that time. Not only that, the insulin concentrations went down at that time. The C-peptide concentrations went down at that time. And this is when we reached Dr. Ravinder Singh and said, can you help us here? We are just completely lost of what is going on. And of course, with the remarkable meticulousness, which has been completely published recently, went through measurement of aspart insulin, bovine insulin, detamir insulin, glargine insulin, lispro insulin. All of them were negative, except glulicine insulin was present in blood. So this patient was injecting glulicine insulin, which is not picked up on our assay, and this is this insulin that is causing hypoglycemia in this patient. So now it is insulin analog-induced hypoglycemia, something like insulin that is causing insulin action, which is causing hypoglycemia. So if there is insulin action, we document that by measuring beta hydroxybutyrate and glucose response to injection of glucagon. And if there is no insulin action, it is not caused by insulin. Even starvation can cause low glucose. And there are some in children, metabolic defects, etc., can cause hypoglycemia. I'm not discussing about children. But if there is insulin-like action, we want to see if the insulin level is around. And if there is no insulin, well, there is something like insulin that is causing hypoglycemia. So we've reached here so far.
In 4 cases, there are few questions. So can we finish those first?
Yeah, sure. Let's start.
And have the other 4 cases.
Sure.
So Swati was asking.
Can we have a mic here, please?
Yeah. No, please. I can repeat the question. Go ahead.
No. That will be better.
In this case, the serum insulin is also low. Actually, when one is fasting, the insulin is definitely, when it's going into starvation or a long time of fasting, then insulin does become undetectable.
But this is, as you can see
But
here,
then if the patient was injecting glulicin, C-peptide, yes, it's an endogenous because of the, so it was low. But why the insulin also was not showing, that was my question.
glulicine is not picked up by
It's not picked up.
human insulin assay.
But as such also, if one is fasting, then wouldn't the insulin also drop?
Insulin goes down gradually. This is rather sudden decline in insulin, as you can see here. And this is hypoglycemia. There also, if fasting glucose goes to 40, 50, insulin goes down because there is no need for insulin.
Yes,
Here
yes.
also injected insulin, so glucose went down to 40 and there was no need for insulin, so insulin secretion stopped. So both ways, we were talking about the same thing.
Right. Okay.
Other case where you had shown that the plasma glucose was normal and the capillary blood glucose was low.
Okay.
And patient was having symptoms.
Yeah.
So with the 40 milligram, he was having symptoms.
Yeah.
And the capillary blood glucose, which was checked multiple times, was showing 40 milligram.
Yeah.
And plasma glucose was normal.
Yeah.
And we have said that there is no hypoglycemia. So what to do?
Hypoglycemia.
I agree, but what to do with the patient? What's the symptoms? How will you?
We have to figure out what is it that is causing the symptoms, not what is it that is causing plasma glucose to be low. Because
I
plasma
agree.
glucose was not low. So investigation of hypoglycemia is not to take place. Investigation of cause of those episodic symptoms need to take place. And we can discuss why their capillary glucose is low because blood circulation is less. People who have vasculopathies, microvascular disease, their capillary glucose is low. People have sensor glucose going low when they have shock or they have so there are many reasons why glucose transport across the capillary is not taking place as fast, and the glucose measurement is low, or in capillary is low because blood is flowing slowly, whereas plasma glucose is fine, brain is getting good amount of glucose. Patient is having symptoms. What is the cause of symptoms we need to look at?
And the other with acute myeloid leukemia, that patient was having the plasma glucose low and the capillary was normal. So it means the lab, when they are sending the reports with the patients with malignancy, if low sugar is there, we have to depend more on the capillary glucose?
Well, in case we need it, this was not needed. This was incidental finding.
Okay.
So we don't have to repeat it. The question was why we were consulted because glucose was 21. They panicked and they called endocrinology.
Okay.
So, and that was, of course, white cell was chewing up the glucose. So nothing needed to be done for that patient. We just confirmed it by capillary glucose. That was okay.
Thank you, sir. Next case.
Okay.
Time lapse of the lab transfer.
Moving on.
sample.
Where was I? Yeah, I did this right already. Yes. So 65-year-old. God. Okay. 60. Yeah, this patient. Sorry, I go back. 27-year-old nurse with spells of low blood sugar had blood drawn during her classic episode in the morning. Actually, she came for a 72-hour fast. She was ready by the time we finished everything, including glucagon, etc. In any case, low glucose, check. Beta-hydroxybutyrate suppressed, check. High response of glucose after glucagon, check. The insulin action is checked. Insulin is very high. Insulin is causing insulin action now, but there is no C-peptide. Proinsulin is rather low. So this is implying that this is injection of insulin that is causing it. So straightforward, okay? So if there is insulin, C-peptide and proinsulin is suppressed, then insulin is being injected. Now we already reached there, right? This is a 66-year-old woman, disoriented, adrenergic symptoms, neurological symptoms with activity, plasma glucose 53, proinsulin is 42, insulin level was 100. C-peptide is 2.33, and insulin antibodies were present. This is a patient who had brought these reports with her. These are her glucose concentration. The lowest glucose we actually did not fast her, and she is going to come back for fasting, and we can discuss that with some more. But glucose was 60, insulin level was 576, C-peptide is 3.2, proinsulin is 42. So what you can see here, low glucose, check. Insulin action, check. We did not do 72-hour fast, so I don't have glucagon injection and glucose response. High insulin is causing insulin-like action, which is causing low glucose. If 60 you want to call low glucose. C-peptide, proinsulin are not really suppressed. They're pretty generous, but they are nowhere what insulin levels are. Insulin levels are sky high, and C-peptide, proinsulin levels are a little high, not too high. So in situation like this, what we do is we measure insulin to C-peptide ratio, and if it is way much in favor of insulin, then it would imply that there is something that is binding insulin and releasing it some other time and causing hypoglycemia. C-peptide has a half-life which is not bound. The antibody is just to the insulin and not to C-peptide. We measured antibodies, they were positive again, and the free insulin concentrations were not all that high, though they were still high for 60 glucose, but they were not all that high as 576, all implying that this is actually an autoimmunity to insulin causing hypoglycemia. All right, if there's autoantibodies, it is autoimmune hypoglycemia. 57-year-old woman with low blood sugar, documented in spells, low glucose, check, insulin action, check, insulin level present, insulin causing insulin-like action, insulin is being secreted. So this is, now we know it is endogenous because C-peptide is not suppressed, endogenous, insulin-induced hypoglycemia. So what is more likely in this situation? Could it be sulfonylurea? Could it be insulinoma? Could it be hyperplasia of the beta cells, islets? What is it that could be? And of course, any of the above is possible. All three of them cause endogenous increase in insulin secretion. And this patient actually was taking glimepiride on purpose. So it's very, very important. You cannot look at the patient's honesty and sincerity and education and anything else and say that the patient is not taking it. This patient actually had a CT scan before glimepiride was picked up, which we rarely do CT scan before all the results are ready, but somehow with scheduling issues, CT was done sooner, and then of course that was a waste of money, but that's besides. So the sulfonylurea meglitinides are present, and of course it is drug-induced release of insulin which is causing hypoglycemia. 71-year-old man, episodes of confusion, low glucose checked, insulin action checked, insulin secretion checked. It's interesting, I can discuss this further. Insulin concentration is rather low, but if you compare that to C-peptide and proinsulin, they are rather generous than insulin. And insulin is short half-life, remember that. So C-peptide and proinsulin are better markers of insulin secretion than insulin itself is, as long as there is no renal failure. And then hypoglycemia agent screen was negative. So now this is what we're dealing with, this spontaneous, endogenous, insulin-induced hypoglycemia. So if there is spontaneous, endogenous, insulin-induced hypoglycemia, except in certain situations, which I'll come back to, we are taking the patient for surgery. Before the surgeons take the surgery, they want to do 4D CT scan, they want to do endoscopic ultrasound, selective PET. If that doesn't show up, I do more invasive as the next step. The least invasive first is the CT scan, then endoscopic ultrasound, then calcium stimulation of the pancreas by injecting calcium in the arteries that deliver pancreas, and we can discuss this if you want. And rarely, if ever we do rotate PET scan, it is not 100% sensitive as it is in neuroendocrine tumors of pancreas otherwise. And this is what happened with the patient. The surgery happens. Soon after surgery, you remove the tumor, glucose concentration goes up. Why? Because the rest of the beta cells are all sleeping in the rest of the pancreas. So they have hyperglycemia for a day or two. So this is lasted for almost a day and a half, actually 3, 4. For half a day, it was very high. After that, it was still generous glucose concentration, 150, 160 glucose concentration. And then it settles down over a period of time unless we remove substantial amount of pancreas. This is another patient in that regard, but we'll skip that. Okay. So this is the last patient, a 43-year-old woman who underwent a gastric bypass 4 years back. She had typical postprandial symptoms, low capillary meter glucose, many times documented. She had an oral glucose tolerance test done somewhere else, which showed at 2 hours the glucose, plasma glucose was 32, and insulin concentrations were rather high. So this is what patient came with, and the patient then underwent a 72-hour fast. This is what happened in 72-hour fast. As the patient fasted, the glucose concentrations went down, and they were, this is all plasma and serum, plasma and capillary are put together, but they were hovering around below 50, below 60, above 60, in that range it settled down. But as the glucose concentration was low, the ketone concentration, the beta hydroxybutyrate concentrations kept going up. That would imply then that there is no insulin-like action that is causing glucose concentration to go below 60 any number of times. That is what's happening. And after injection of glucagon, the glucose did not increase by 25 points, implying that there was no insulin-like action, which was causing glycogen storage, which was released by glucagon. So now we know there is not insulin-like action. So this essentially is normal fast. If any one of us fasted, this is what will happen. The glucose concentration will go into 50s or even 40s after some time, and ketone levels will go high. There will be no insulin-like action. So this is normal fast. So this plasma glucose is not hypoglycemia at this moment in time, just an asymptomatic plasma glucose. So then what happened is that I said, well, I don't know whether you are having hypoglycemia or not, because we have never had a plasma glucose drawn for you, except for glucose tolerance test, and we'll discuss about that in a moment. So I said, can you document a plasma glucose? And this, after this particular patient, I changed my practice, but I said, do what you want. Get an episode, collect blood. So of course, what she did was she took 2 donuts and mojito. Mojito is an alcoholic sweet drink. And after that, she had low glucose checked, insulin action checked, insulin secretion, insulin levels checked. So now what we have is hypoglycemia caused by insulin secreted after consuming fast-acting carbohydrates and alcohol in a patient who had had gastric bypass. So let's briefly see what on earth is going on. This is glucose tolerance test data from Denmark in women who are undergoing gestational diabetes. The glucose concentration increases after glucose and then comes down. First thing to point here is that this is pregnancy, but even non-pregnant women and some men, glucose concentration going below 60 is not necessarily abnormal. Glucose concentration going below 70 in normal, non-diabetic individuals who don't have impaired fasting glucose is completely normal. If I put CGM on all of you will beep sometime during the day. And that's not necessarily abnormal. So first thing there. But compare this now to women who had gastric bypass. This is their glucose tolerance test data. As you can see, seems to be going up a little high, going down a little low, 2 hours. Such that almost half of the women glucose concentration was below 60, and some had actually glucose concentration going below 30 milligram per deciliter. And this is not capillary glucose, this is not sensor glucose, this is plasma glucose. None of these patients are being investigated for symptoms of hypoglycemia. This is just pregnancy, gestational diabetes, screen, etc. This is the physiology after gastric bypass. This is what happens after gastric bypass, and that happens because in normal stomach there is a valve at the end of the stomach. So when we eat, food comes and stays in stomach, and it takes some time for food to get out of stomach, such that it takes about 2 hours, 3 hours for stomach to empty and release its content into the small intestine. And as the food is going to small intestine, we taste, we smell, we absorb some of the food, we release insulin, and the bottom line is glucose concentration goes up and then it goes down, and then before it goes down too low, we release glucagon. But whatever reasons, it goes up and it settles down after some time. Some points may be lower than what it started from, but this is the normal response to food. What is happening in gastric bypass is that there is no valve on the way to food. The food is being dumped from esophagus straight into the small intestine. Same is true with gastrectomy and different types of, sometimes even without a surgery, if the valve is incompetent, food goes dumped straight into the small intestine. Now what is happening is food is getting absorbed in a much shorter period of time. It is the same amount of food being absorbed in both instances, but now in a very short period of time. And the second thing is that the food that is expected to come out over the next 2 hours is missing. It's not coming out because everything has come and everything is gone. Because a lot of food is being absorbed in a very short period of time, we release a lot of insulin, of course. And if we release a lot of insulin, what happens is glucose concentration now goes low because of a lot of insulin, and because there is no more food coming that was supposed to come out after the first dumping that happens, right? So this is typical of dumping syndrome when there is hyperinsulinism, hyperinsulinemia, which causes hypoglycemia. But of course, there is another component of dumping syndrome in which the concentrated food appears in small intestine, which releases small intestinal hormones and fluid shifts, etc. Sum total is that they have vasomotor symptoms. So a lot of similarity between this dumping and that dumping and all of them dumping put together. And often there you cannot even figure out as GI dumping or endocrine dumping. And of course, dumping does not necessarily have anything to do with taking a dump. Somehow people believe that that's something to do with diarrhea. Diarrhea is a part of dumping syndrome and GI dumping, but it does not necessarily have to be there. So that part has to be clear to us and to the patient as well as to understand. So what should we do in a patient who had GI surgery or we suspected dumping syndrome? First of all, of course, we have to document hypoglycemia by Whipple's triad. If there is no hypoglycemia, well, if there is hypoglycemia, we want to figure out if this is insulinoma or not. We have had at least 2 patients who had gastric bypass and had insulinoma also. So it's not that it cannot happen, it's exceedingly rare. We see more insulinomas than anywhere in the world. but we see the rarest of the rare. So we have seen it, but it's not very likely. But in any case, if there is insulinoma, of course, we proceed with surgery. On the other hand, if the patient does not have hypoglycemia, we want a GI concern. We want to see if GI people can help with the dumping syndrome and the symptoms related to dumping syndrome management of it. And if there is no hypoglycemia, there is no insulinoma causing, but hypoglycemia was present, but not because of insulinoma, then we want to go to dumping syndrome. Ultimately, management is about the same for dumping syndrome. What is the management? We want to modify the diet, what is called dumping diet. We separate out solid food with liquid, smaller amounts, etc. And Dr. Meera Shah is here. She can tell you much more about it. She does a lot of bariatric surgery, etc. And then we want to add edible gum, this good old guar gum we add to food that slow down the transit of food. That'll take care of both GI and endocrine dumping syndrome. If that doesn't work, we want to use only small doses of only short-acting somatostatin, not long-acting somatostatin. Only short-acting somatostatin taken 20 minutes before eating, 15 minutes before eating, half an hour before eating, sort out what controls the patient's symptoms. And then if that doesn't work and hypoglycemia is present, people do crazy things. I've never done this, frankly. So the bottom line is, for these issues like this, and we have sent patients for reversal of gastric bypass, it never helps. I can tell you that none of the surgeries, actually for what they're called, Tori procedure, etc., may help. They change the size of the anastomosis, but other than that, I don't know if any other thing helps these patients. The bottom line is, patient has to understand that we will not be able to change physiology. Glucose will go up and glucose will go down. That is how it is. If you put a sensor on them, they will have glucose going up and down and beeping in both directions every day, and there is nothing I can do about it. What they have to understand, that the episodic symptoms that the patient is having needs to be reduced. We need to reduce the severity of episodic symptoms. If they're passing out, then how can we reduce it, etc. Those things need to be taken care of, and that can happen because, of course, GI dumping as well as endocrine dumping. Mostly vasovagal, etc., is from GI dumping, not from endocrine dumping, but that is what patients should understand, and that's what we target in treatment. So we discussed about the post-meal hypoglycemia in those who had gastric bypass or sometime even without a surgery. We discussed how to deal with it. It's essentially multifactorial GI symptoms, endocrine symptoms, and the management strategies, as I briefly discussed, are all listed here. Other thing to remember is that oral glucose tolerance has absolutely no role in diagnosis, in differential diagnosis, in management, or anything related to hypoglycemia. If hypoglycemia is caused by oral glucose tolerance test, the prescription is don't eat glucose. There is no other prescription for that. So thank you so very much. I brought my last slide again. Yes, I'm ready for the questions, and I brought the same slide all over again. Let's go.
No worries.